Patients in prolonged disorders of consciousness need specialist seating, very often tilt-in-space seating with extra accessories to help get as good a posture as possible. And this is because they don't have active sitting balance. They're not able to control their muscles, sit upright, they can't change their own position, they can't relieve their pressure if they're uncomfortable. Spasticity is often a problem, and that will lead to possible postural changes or even postural deformities. Very often you find patients in prolonged disorders of consciousness, perhaps suffered a polytrauma, multiple injuries, the nature of the accident, so there might be orthopaedic considerations. So very often you're looking at a very complex package, you're looking at everything, it's not just seating from a neurological point of view. As the occupational therapist, the way I work is tend to do joint assessment with the physiotherapist, looking at the full postural assessment, so in lying and in sitting, and looking at full range, everything, ankles all the way up to head control, but with seating paying most particular attention to the pelvis, especially in sitting. That's where you start. You look at, is the pelvis right? And from there work up. I've lost track of how many times I've been called to, the headrest is wrong, the head isn't in the headrest, the head's to the side, we can't, what can you do to keep the head back? And it's like, well, the head is only ever going to be resting over here because everything else is out of alignment. So you're very often having to go back and look at what's the best position at the hip and pelvis here. And if you can correct that, and then you'll look up the trunk, and we're maybe looking then at lateral supports or thoracic supports that you can insert into the wheelchair or into the backrest cushion to maybe get a slightly better trunk position. Then you find the head's in a completely different place. So then you look at the headrest. So, you're having to look at the whole person for seating. Very often, arms and legs will be positioned differently. One side may have higher tone than the other. One side may have had very complex fractures and you've lost some range, or they're fixed in a certain position, so you might need elevating leg rests. They might be fixed, with the toes pointing down, so they're plantar flex. You've lost that range at the ankle, so you're having to angle foot rests, or finding multiple use for pillows and cushions in trying to support as good a posture as possible.
So can you explain to me just the difference in the seats? So for a disorder of consciousness patient, what seating options might there be, and what do each of these seats do, and what's the point of them?
Okay. I would be looking at something that I can get, a seating system that I can use to get someone from one environment to another. So I'd like to get a resident out of bed and into the day room. That could be a seating system which hasn't got wheelchair wheels. Ideally, I'd like wheelchair wheels on a seating system because that means I can get the person into the garden. Or I've got families that like to take their loved ones home or out for the day. So I would always opt, if I was told I can only have one seating system for a resident, then I would always recommend and fight for something on wheels, a wheelchair base, which gives us the option of going other than from bedroom to the day room. But we do have residents who we can't sit into a chair which goes at 90/90, a standard chair. Most residents would need a chair with tilt in space, and possibly a recline function as well. But we do have patients with moulded seats.
And when you say moulded, there's literally a plastic mould that gets moulded around their body specifically for them in a certain position.
Yes, the new technology that's been used at the moment is brought in on site, so we don't have to take our residents to a clinic anymore, which is great. So you imagine if you're trying to take a resident to a clinic, if you've got suitable seating, you're looking at a stretcher, so you're having to look at contacting the hospital, getting an ambulance and a stretcher. So now the moulds can happen on site, and then once you've got the mould, you can then go to clinic. And the way that it's done currently is a beanbag. So a standard chair, then a beanbag is put on it, which is full of micro beads, which then gets moulded to you, and then the air sucked out. So you've got a vacuum. Seat base. It could be a seat base. We've recently moulded a back and a seat and put them on a wheelchair separately. So once the mould's done on site with the resident hoisted on, then the technical bit happens, and it gets scanned, like you're in a shop. It gets scanned, and a 3D picture gets brought up on the computer, and then that's what's taken away. And then the foam mould, most of ours are foam, get made from there.
And someone who might need a moulded seats, might they have contractures or changes in their joint range of movement or something? What are the situations in their kind of physical presentation that might require them to have a moulded seat over something else?
Those that need moulding have got fixed postures or deformities. So if I've got someone who we can no longer get their pelvis symmetrical and we can't compensate that in a normal cushion, then we're going to have to start looking at something moulded. Same with shortening in the trunk muscles. We've got kyphosis, which is fixed. You physically can't, you just can't. You would have to have something moulded. So sometimes we can mould and have it all in one. So you've got the mould, the back and the bottom moulded into one. But if there is some changes in we're not fixed necessarily in how much range we've got in the hips, then we might want to look at having a recline, and depending on how fatigued.
Very often as an OT, when I was based on a ward, or if I was based in a care home, then the wheelchair would come, and that would be something that I would help set up, or I'd help maintain and monitor, and training to staff or carers involved. A lot of these wheelchairs, they've got different features. You can tilt them, you can recline them, and actually as a therapist I might want you to tilt, but please don't ever touch the recline, because I don't want to lose the hip angle, but I do want to be able to help tilt the person, to help change their position, and to help gravity do its job, as well, helping positioning of the head and such like. So I think very often part of that seating handover should include, a little bit of education as to the maintenance of the wheelchair and best positioning, and some troubleshooting points, because very often it's the hoisting in the first place. If you haven't got that right, or you just were a bit not far enough back, or person had an associated reaction and went into extensor pattern, so they went quite straight and rigid, and actually, that's where you get the phone call from other carers or staff saying, the belt doesn't fit. And it's like, the belt would fit fine if the person were right back in the chair, however, they're several inches off where they should be, so don't tinker with the belt. It fit the day it was set up, so it should fit, so look at the other areas first. And so the hoisting, so I tend to try and do a bit of a package for carers, relatives even, looking at seating and how you get the best position, because it's a big area, and it's very difficult to get right. Spasticity can change, people's level of awareness changes. These things all affect posture and how well someone's able to sit, how well they are even, if someone has a UTI or a chest infection, they have other stresses on their body, spasticity at that point might become worse, they might become tighter, more rigid, more difficult to hoist, therefore more difficult to seat. They fatigue quicker because they're maybe not feeling as well, and all these things impact, so even if you've got someone and the OT has very nicely said, no, this person can sit for 4 hours, actually maybe not maybe not every day. Maybe someone isn't that well. Maybe, you know, carers will pick up, family members will pick up. Maybe someone's fatiguing quicker. So I think, you know, I suppose what I'm saying is it's an area that you're always having to look at. It's not just, there we go, we've done an assessment, we've provided a wheelchair, job done. You know, very often there's a lot more that you want to keep looking at.